Next up is Dr. Kimberly Chapman, who will provide a clinical overview of classical homocystinuria. This will serve as a scientific foundation for this morning's discussion. Dr. Chapman is an attending physician in genetics and metabolism at Children's National and assistant professor of pediatrics and integrated systems biology at George Washington University. She specializes in taking care of all ages of individuals with defects of methylation, homocysteine, propionate metabolism. Dr. Chapman, over to you.
Thank you so much for that really nice introduction. So today I'm going to talk about the homocystinuria, and where we're going to really focus on is cystathione beta synthase deficiency or CBS deficiency. As you may know, there's a number of homocystinuria, and these all require different therapies, different management, are caused by different genetic disorders. Today we're really going to focus on cystathione beta synthase. So let me talk a little bit about my conflict of interest. I'm a medical advisor and board member for HCU Network America. I'm a medical advisor for Travere, who currently has a therapeutic and clinical trial, as well as being a PI for the Travere CBS Natural History Study, also known as Acapella. So the homocystinuria, there's basically three large categories of disorders that are included within the population of homocystinuria. There's the remethylation defects, the cobalamin defects, and then the CBS related defects. And so within the red circle is where our remethylation disorders are. And in these disorders, we accumulate homocysteine because we're unable to convert homocysteine to methionine. The cobalamin defects, as designated by the yellow arrow, are caused by the inability to process cobalamin, or B12. And again, these are necessary for methylation, and they're necessary to convert homocysteine to methionine, and are treated in a different way. Finally, there is the CBS defects, and these are caused by the inability of cystathione beta synthase to convert homocysteine to cystathione. In this particular cycle, methionine that arises from the diet is converted to homocysteine. Homocysteine is then converted to cystathione by CBS. CBS is a B6 or pyridoxine responsive enzyme, and that is necessary for its metabolism. Individuals with this type of homocystinuria not only accumulate homocysteine in their blood and urine, but also have elevations in methionine. Methionine is an essential amino acid and typically enters the cycle through the diet. Individuals with cystathione beta synthase deficiency, but not necessarily all of the other homocystinuria, have a number of very common disease manifestations. And the four big categories that are involved here are the CNS, or the central nervous system, the eyes, the skeleton, and the vascular system. In the CNS, you can see psychosis, mental health difficulties, but you can also see intellectual disability in individuals that aren't adequately treated, and a number of folks will develop movement disorders or white matter changes with age. The eyes, the classic presentation is atopic lentis, and many individuals have severe myopia. For those who are not identified by newborn screen in the United States, ophthalmology and optometry are usually the first touch base for a number of these complications. And because atopic lentis is fairly rare, these individuals present oftentimes to optometry or ophthalmology. The skeletal abnormalities are the things that most medical textbooks include, and these include excessive height, incredibly long limbs for the size of the thorax, and then individuals often develop osteoporosis with age, whether they're treated or not, and have a number of bone deformities. These things are often reflective of a different genetic disorder, which is called Marfan syndrome. And so some individuals with CBS deficiency are identified when they're being evaluated for a disorder like Marfan syndrome. And finally, there's the vascular system. And this is potentially, arguably, the most life-threatening system because we see a number of thromboembolisms. Anybody with an elevated total homocysteine greater than the 100 micromole to 120 micromole per liter level are at risk for having spontaneous thrombosis. These are mostly venous versus arterial. And so individuals can present with blood clots in their lower extremities as deep vein thrombosis. They can have pulmonary embolisms, or the most frightening is stroke-like episodes. Individuals who have these types of strokes present like a stroke. They're often at earlier ages, and can be life-threatening, impacting both morbidity and mortality. So we're talking predominantly about CBS and CBS deficiency. CBS deficiency is caused by dysfunction of the cystathione beta synthase gene. This is usually a dimer and is illustrated here in the right side of your slide. It's encoded on chromosome 21 at Q22.3 and has 23 exons or coding regions with intervening sequence between. Mutations in CBS are seen pan-ethnically, but there's certain locations that are more commonly represented because there's a higher carrier frequency. And two of the most common places for this are within Cutter, where the carrier frequency is very high, and in fact so high that the newborn screening does not look for elevation in methionine, but goes directly to elevations in total homocysteine, and then in a number of some of the Irish population. As I said, cystathione beta synthase is pyridoxine responsive. Pyridoxine is vitamin B6, and there's a number of common mutations that are seen, such that approximately 50% of the population is estimated that has CBS, has this B6 responsive type of thing. The pyridoxine responsiveness, probably the most common variant, is this isoleucine 278 to threonine, although there's a number of other known pyridoxine responsive genes. Individuals who are homozygous for these genes are almost always pyridoxine responsive. Those who are heterogeneous, such that they have one of these pyridoxine responsive and one of the more severe mutations, typically are either partially responsive or not responsive to pyridoxine. So part of the reason I'm presenting this particular thing is because I sit on one of the major guideline groups that has produced recommendations for diagnostic and treatment for cystathione beta synthase. And so how do you diagnose this disorder within the US population specifically, but in the general population? Well, most states in the United States have newborn screening, or NBS, and most states in the United States, as their primary screen, looks for elevations in methionine. It is important to note that if you look predominantly at elevations in methionine in newborn screening cards, you're likely to miss the B6 responsive patients. And in the US, the estimate is approximately 50% of individuals with CBS will be pyridoxine responsive or partially responsive. And the reason this is the case is because individuals with B6 responsiveness or partial responsive do not have elevations in methionine high enough above the cutoff. There are a few states which are either looking at whether they do dual testing for total homocysteine plus methionine, or looking at serial testing. Individuals above a particular cutoff of methionine would then have a secondary screen using total homocysteine. In the state of Qatar, or the country of Qatar, their screen, because of how high and what a high frequency it is in the disease, is actually looking directly at total homocysteine. Now, the vast majority of individuals within the United States are either older and were not newborn screened, or are missed by the newborn screen. And those folks usually present in a symptomatic way. And we talked a little bit about what the common disease manifestations are. And so these individuals may present to their pediatrician or to a developmentalist with some intellectual challenges or learning challenges. They may present to psychiatry with some of their psychiatric disease. They may present to orthopedics. They may present to a geneticist with a rule out Marfan. They may present to ophthalmology. Typically, the way that you make the diagnosis, at least have the first hint that this is the diagnosis, is to look at somebody's total homocysteine. Individuals with total homocysteine greater than the normal range, and in most labs, the normal range is approximately 12 to 15 micromole per liter. And many individuals with these disorders will be much higher than that. We talked a little bit about epidemiology and that this is a pan-ethnic thing. The epidemiology in Qatar has a very high frequency. We're saying about 1 in 1,800. This is because there's a high carrier frequency due to a founder effect. So an individual back in the past who had a mutation within this gene. The estimate worldwide is about 1 in 900,000. If we start looking at the populations that we see within the United States, we generally say that those from the Asian continent have a fairly low frequency. Those of African descent also have a low frequency. Non-Finnish Europeans are about 0.82 per 100,000. And then some of the other estimates are about 0.39 per 100,000. Within the United States, we know that there's probably more individuals with homocystinuria and CBS deficiency specifically, and part of this is because approximately 50% of individuals within the United States, knowing where our populations come from, are likely to be B6 responsive. And at this point, I'd like to thank HCU Network America for allowing me to do this talk, and then our patients, faculty, and staff at the Children's National Rare Disease Institute. Thank you so much.